Welcome everyone to the Special Populations Core 2023 seminar series of the New Jersey Alliance for Clinical and Translational Science. Thank you for joining for today's presentation. We're very excited to have Dr. Jonathan Cantor of the RAND Corporation with us to discuss geographic distribution of substance use disorder treatment facilities in the United States. Before we jump in, if you do have any questions during the talk, please feel free to unmute and ask Dr. Cantor during the presentation. We'll also have moments at the end for Q&A as well. To get us started, I'm going to turn it over to Jim Lloyd, who is a research specialist here at the Rutgers Center for Health Services Research, to introduce Dr. Cantor. So Jim, over to you.
Thanks, Kylie. I'm really excited to introduce Dr. Cantor for this presentation. He is a full policy researcher at the RAND Corporation. His work focuses on the impact of government healthcare programs on substance use disorder and mental health treatment. He employs theoretical frameworks and research methods from health economics, policy analysis, and public health. And his published articles have appeared in journals including JAMA Network Open, JAMA Health Forum, JAMA Psychiatry, Health Affairs, the Journal of Health Economics, the New England Journal of Medicine, and the American Journal of Public Health. He is a Doctor of Philosophy in Public Administration from the Robert F. Wagner Graduate School of Public Service at New York University. And I'm going to turn it over to him for this presentation right now.
Thank you for the introduction and for the opportunity to present this work. I am Dr. Jonathan Cantor. I'm a full policy researcher at the RAND Corporation, located in very rainy Santa Monica. And this is a discussion of a paper that was recently accepted in JAMA Network Open. The nice thing about discussing papers that have been accepted is that while you can receive feedback, it'll help with the next research idea and the next project or paper. Feel free to interrupt at any point in time. I've left plenty of time for questions and for feedback and comments. I'm hoping that folks here will be able to give us some really good ideas for next steps, given we're working with a very unique database that took a lot of time and effort to collect data for and create. And there are still a lot of outstanding questions that could be answered using these data. So as everyone here, I expect, knows, rising drug overdoses is a pressing and urgent public health problem. There's been a drastic increase in the number of drug overdose deaths in the US since 1999. But one thing that's really important to note is that the increase is not uniformly distributed across the country. There's lots of heterogeneity here in terms of where the increases are occurring most rapidly, as well as other areas of the country where they're not occurring as rapidly, but there are increases. So a lot of the geographic disparities and differences are linked to other local contextual factors. This includes the local unemployment rate, the local poverty rate, education levels, and urbanicity. It's really important to consider the fact that a lot of these disparities are at either the state or even at the county level. And so we really need rigorous data approaches that incorporate local contextual factors to see which areas of the country are disproportionately impacted or not, as well as which areas of the country have treatment or not. So I'm going to frame this study both on older adults and then also on opioid use disorder, but it's not necessarily restricted to either of those things. Treatment access in general is difficult for all Americans. Relatively few individuals actually get treatment, but it's particularly difficult for older adults. For example, the number of Medicare beneficiaries with substance use disorder is growing rapidly. And as a result, we need to have more treatment resources available to meet this ever increasing number of individuals who are suffering from substance use disorder. About 11% of Medicare beneficiaries with a substance use disorder received treatment in 2018. And many beneficiaries report either limited geographic availability or limited affordability in treatment for not receiving treatment. The affordability piece is usually linked to work related to Medicare, mostly the fact that Medicare may not be the best payer and that substance use treatment facilities may not accept Medicare as a form of payment in a lot of cases. Similarly, relatively few more older adults live in rural areas. So it's in general more difficult to reach a treatment facility. So combining the fact that many older adults live in rural areas with the fact that relatively few Medicare facilities accept Medicare as a form of payment, it's kind of a pressing problem. For example, in 2017, less than half of substance use disorder treatment facilities accepted Medicare as a form of payment. I'm going to show you some numbers about what the rates look like now and how they've changed over time. There are also, this is a very, very hot area of research, given the fact that it's becoming a bigger problem since the number of individuals with substance use disorder and Medicare are increasing. So there's been a lot of research in the past few years looking at this question about why are individuals on Medicare not getting treatment and how we might remedy that. For folks, just in case that don't know anything about medications for opioid use disorder, I make reference to it a couple times during this talk. The number of older adults that have received treatment for opioid use disorder has almost doubled since 2007. For those folks that don't know, MOUD is an effective form of treatment for opioid use disorder. And there's 3 forms really, buprenorphine, methadone, and naltrexone. And relatively few treatment facilities offer all 3 of these forms of MOUD for treatment. You might have 1, you might have 2, but all 3 is very rare in many cases. So again, thinking back to the older adult populations, especially those with opioid use disorder, it's going to be difficult to find a treatment facility that offers all 3 forms of medication for opioid use disorder, that accepts Medicare as a form of payment, and that's located in a rural locality, for example. So there's multitudes of issues here in terms of trying to figure out why treatment rates are so low, even if they have been increasing since 2007. I'm going to give you a little bit of a discussion about why a treatment facility is important. There's been a lot of research about what a specialty clinic or treatment facility has on local health and societal problems that are related to substance use disorder. So it's been shown in the literature, at least, that a substance use disorder treatment facility within a county, for example, reduces the number of drug overdose deaths. This is an economic study in the Journal of Public Economics that looks at changes in the number of substance use disorder treatment facilities within a county and its impact on overdose deaths. And as the number of treatment facilities increases, the number of drug overdose deaths declines. It's also been related to reductions in the number of suicides, and then reductions in the number of violent and financially motivated crimes. Probably the most relevant, at least for this audience, is this particular paper that was recently published in the Journal of Health Economics. Here, the authors found that changes in the number of substance use disorder treatment facilities within a county led to a decline in the number of drug-related emergency room visits. This particular study is also important because it's the most similar to the work that we've been doing, related to the collection of specific licensure data, whereas their studies limited to just the state of New Jersey. We've collected data nationally in scope.
Their study was in New Jersey and it used fixed effects.
Yes, I believe so. Yes.
Interesting.
Yeah, and they've it's a very good study. I was happy someone did it, at least for one individual state, but we've tried focusing on at least the national level. We're not going to look at that particular research question, though we have explored trying to, but it is something that we want to try and replicate at some point.
And this is you say having an SCD treatment within a county, but we have large counties, we have large population counties, so it's kind of a metric of the number of facilities relevant to some denominator.
This is okay, yeah. So many of the studies here use changes in the number of treatment facilities to measure openings and closing. Right. Yeah, but you're hitting on some issues that I'm definitely going to get to. Mostly about how this is a really coarse measure for trying to measure accessibility. And it's even limited in the sense that we're only here talking about the specialty sector. We're not even talking about primary care physicians or other individuals who are like waivered, buprenorphine waivered physicians.
But you're including all of those irrespective of what treatment they're actually giving, whether it's medication or psychosocial, residential.
These studies usually are, yeah. So I would
Yeah.
say that the first 3 bullets do, I think the 4th one as well, but we have much more detailed measures about the actual facilities themselves that we can incorporate. Feel free to keep asking questions too. And this might help as well. This is a discussion about mostly what data are available because it's rapidly changing, actually. So for folks who don't know, the Substance Abuse Mental Health Services Administration each year surveys all substance use disorder treatment facilities, and then separately all mental health treatment facilities. Now, they've recently combined both surveys to make one mega survey to streamline the collection of data. Now, historically, the National Survey of Substance Abuse Treatment Services collected data on all substance use disorder treatment facilities in the US. Now they've merged it to a mental health survey, and you're now, I think in 2022, the National Substance Use and Mental Health Services Survey. So whereas there was 2 surveys previously, there's now 1. I'm going to just call it the NSATs just for the ease of not driving everyone crazy. So the NSATs are cross-sectional survey treatment facilities. Again, they're trying to reach every single treatment facility in the US. That includes both licensed and unlicensed treatment facilities. The lowest geographic identifier was county until 2012. Now the public use files only have state.
Can you, when you say non-licensed treatment facilities, they're facilities, they are not individual medical offices, but they are not licensed?
Yeah, that's at least our understanding from reading the documentation, that these are treatment facilities. These aren't private, these aren't like actual just physicians' offices.
And this would be sort of like in less regulated states where you have residential care that's not regulated or something of that sort, or
I haven't seen anyone do any analyses related to those data in terms of what services are offered by unlicensed treatment facilities. They are identifiable, I believe, in the NSATs. They aren't in our data, but you could probably look at state licensure data and merge it to see whether or not there are differential rates of unlicensed facilities based off of state licensure data. It's something that folks have told us it's something of interest, is to take state licensure data and try and match it up to the licensed facilities and see whether or not certain states are doing better or worse. Every time we've tried to actually pitch that as a research project, we haven't been funded as of yet.
Interesting. Thereby showing the foolishness of the comment that I was thinking of making, which is that a logical direction for this line of research that you're going might be to sort of look at this whole mess of state licensing and how it adversely affects access to treatment, particularly for people with multiple conditions. And there's been a lot of reform work on that, but less actual study of it, seems to me.
Yeah, that's one thing that we are very interested in. If we can get actual good data on the licensure process, we could be able to link it up to these facilities and be able to look at what's occurring. As opposed to the NSATs, where it's a little bit more difficult. And some of the limitations for the NSATs in particular, that's a voluntary survey. So you don't have to actually take it. There's no like, yeah, you can or you can't. And there is non-response in it. They actually provide information on client counts on a particular day that the survey is conducted. So you get like a one-off of how many clients or how many beds they have. It's cross-sectional. So, it's not a linked panel. So a facility can be surveyed in one year and not the other. And you're really relying on cross-sectional variation to identify the effects of policies.
So let me ask a dumb question because
Okay.
I suspect I'm not the only person who doesn't understand this relationship very well.
Yep.
What is the relationship exactly between NSATs and TEDs?
So that, okay, now that is the TEDs are a data set of all treatment admissions. Well, the TEDS
Right.
A is, and the TEDS D is discharges. Now we've tried linking up data between the two. The TEDs lack a county identifier. They have a state level identifier, and they have a core-based statistical area identifier. They don't really link up well with the NSATs, but presumably you would have both the supply of specialty providers as well as the demand or the utilization rates within the TEDs.
And is that because of those, because that doesn't require patient identification, but it does require consistent facility identification?
It would potentially, yeah. And so we've tried doing this at the core-based statistical area before in the past. And it's again, another thing that we've like tried getting funding for. It's not entirely easy to get at just because, you know, with the TEDs, they're really restricting the ability to identify particular treatment admission.
Right,
Yeah.
right, exactly.
But I have a little bit later, I have some discussion about how ways that we might be able to get around this. So here's a study or a blog post from 2018 that basically just shows that describes the fact that multiple versions of MOUD are not offered at many treatment facilities in the US. They provide this kind of map out here that shows areas of the country, these are at the county level. So gray areas lack a treatment facility that offers MOUD. And then in darker shading of purple, you can see areas of the country with more facilities that offer MOUD. So the darker the color, the more offering of MOUD. So you can see like that, you know, there's a wide swath of variation here that we're really missing using the NSATs at the state level. So that's one limitation, right? Is this geographic piece, is that we're not getting the variation that we want to see. Then I'm going to show two more health affairs studies real quick that outlines the NSATs limitations. This first one, it looks at trends in the availability of substance use disorder treatment facilities in the county. They use data from 2002 and 2010 through 2010 to calculate where SUD treatment centers were closing. And even in their limitations, they have this nice quote that basically says, like, county is a meaningful unit, but it's really not the best unit. And we should try to get lower if we can, and as more data becomes available. And, you know, it's really sad to see that, like, the NSATs, more recent versions only have the state identifier. So we're actually, like, reversing where we're going as opposed to trying to improve things. Then this other study, more recent in health affairs, also looks at trends in the use of offering of medications for opioid use disorder in SUD treatment facilities, and how that's changed over time. And here too, they also report the fact that they only know the availability, but not the utilization of such treatment resources. And that, you know, even because a lot of facilities claim that they're offering these things, they might not actually be utilizing these forms of treatment. And that's going to be hard for us to actually unpack the relationship between various treatment and mortality outcomes, you know, if we use state level mortality combined with state level treatment facility offerings. So this is kind of like giving you a sense of what the limitations are. So at least in terms of what data we have, we call it the Mental Health and Addiction Treatment Tracking Repository, aka MATTR. So the NSATs, their lowest level geography is state in the public use files, whereas in the MATTR data, we have the street address. In the NSATs, there's no common identifier for facilities across time, so you can't keep track of the same provider over time and see changes within that same provider over time. Whereas the MATTR, we have an identifier, so we can keep track of the same facilities over time and see what they are or not doing. In the NSATs, you can't really adjust for self-selection and response bias, right? Because you can't tell if a facility is taking the survey each year, or which types of surveys are taking the survey each year. And we've thrown a bunch of statisticians at this to try and come up with the best metric for saying, you know, are we overestimating, underestimating, the availability of treatment based off of the fact that we're not adjusting for response bias. And I'll show you a specific example of that in the coming slides. Then kind of getting to Stephen's question, there's no way you can link to claims data in the NSATs. But one thing that we've been doing actively with the matter data is we've been linking it up to Medicare claims data to identify which treatment facilities in the US are providing medications for opioid use disorder and for how many patients. The claims data should be capturing what the TEDS is, in the sense that we're using actual healthcare claims to see what these treatment facilities are doing. Because given the fact that on a survey, they might say, yeah, I'm offering medications for opioid use disorder, but if I go to the clinic, they're really not. And this has been shown by some secret shopper studies where they'll call a facility up and being like, asking specifically, do you accept this form of insurance? It says on your website that you do, and they might say no when you try to reach them on the phone. So we think that like all of these, this is the strict contrast that we have between the NSATs and the data that we've collected.
These data are collected directly from facilities?
The data that we've been, I'm going to give a whole description of how we've been doing this. We're basically piggybacking off of a lot of the work that SAMHSA has been doing, collating it and making it into a usable format. So I'll provide a description of it.
Yes, but at some point, are you going to mention NPIs, like whether you collect the NPIs of the providers associated with the facility?
I can. Yeah, so that is one thing that we are working on. It's an extension that we are trying to do, and I can touch upon that at some point. I'd be happy to. So at first, I mean, we've spent a lot of time collecting these data. I'm going to talk about trends in geographic distribution. I don't have the MPI slides in here, but I could definitely talk about it and how we're thinking about it. And I'm happy to talk offline or answer questions about that as well, too. And last part, I'm going to be discussing possible next steps as well. So the first and third bullet is mostly kind of a discussion of this new data. It's brand new, so we're trying to get feedback about possible uses of it, and then how it might be useful for researchers as well. And the second one's kind of give you an application of this recent study that we've published on the data. So what we do, I'm going to give you a quick overview of this. Essentially what we did is that in the NSATs, you're actually asked if you want to be listed in what's called the National Directory of Drug and Alcohol Abuse Treatment Facilities. So prior to the internet, if folks wanted to get identify where they should receive treatment for substance use disorder, they'd have to go and like pick up these huge directories, these 1,000-page PDFs, and actually actively go through to try to identify a provider. The actual PDFs are indexed at the state and county level. And within them, they include the name of the facility, the address, the phone number, the focus of the facility, the types of services provided, and their payments accepted. And so back in 1975, this is what information they collected. You have the orientation, the type of care, the special programs, and the unit function of the facility. These are all things that they claim to offer at the facility. And I apologize for the coarse language in the special program section. That's the way things were in 1975 in terms of how they listed the types of programs that are listed at the facility. So, it's limited information, but you do know whether or not a facility exists in that particular area of the country dating back to 1975. This is the type of information that you have in 2017. So you have a lot more pieces of information. You have the focus, the type of care, the treatment approaches, the service setting, who owns and operates the facility, the types of payment they accept, the specialized programs, pretty much like, I think over 300 characteristics of the facility. Again, this is supposed to be the way that folks can identify where they should go for treatment, is to actually like identify based off of all these characteristics. So if I'm an older adult that's, paying with Medicare with an opioid use disorder, I might go to a particular facility based off of the information here. So this is how it looks, and like how the data looks in the PDFs. It's basically here. I always like reminding people when it's sunny out, but it isn't today, that RAND is located in Santa Monica. So for this particular treatment facility or drug court program, we can zoom in and see their name, their address, their phone number, and then a bunch of these other characteristics. So we know it's a substance abuse treatment. Services is their main primary focus. The types of care or substance abuse treatment, and then they don't treat for opioid addiction at this particular program. And then there's a listing of all the different types of insurance or funding that's accepted for treatment. You'll note here, Medicare is not one of the options, but things like Medicaid are, and cash and private insurance are.
No mention of this special program to treat burned out RAND employees.
No, there is not, but they do have special programs here. You actually read my mind. Here's the listing of special programs, but that is not listed there. There are tons of different groups, though, that are listed. And you can see there's a wealth of information about the providers in here. So it's, a lot of information that we can use to be able to identify the availability of treatment. I'm just going to give you a quick overview of what we did to get the historical data together. It was a real bear. It took several years. We first OCR'd the PDFs, we parsed the data, we geocoded it, and then we linked it across years. So I don't know if folks would know what OCRing is, but the files we had between 2005 and onward were pretty good in terms of quality, but everything before 2005 was like bad and could be corrupt in certain areas. So we had to actually do manual hand checks. So what did that entail? Well, we had to confirm whether or not it was a Z or a 2 or a 1 parentheses or a 9. And this is the software we used. We basically had to go through, we had some very good RAs who would go through and have to actually confirm whether or not individual pieces within the data were correct or not. It took several hours or several days actually, and we're very thankful for their help. So basically we take something like this in PDF, like dating back in the 80s or 90s, and turn it into an Excel file that looks something like this. So we can actually take the information from each of those PDFs and then make it into a usable format for research purposes, essentially. And we can, being able to actually keep track of where treatment facilities are located and where it's changed over time. So we might take this data and then geocode it. So we used ArcMap to geocode the data. We got about 98% at the address level, which was really good. We were happy with that rate at least. And that led us to being able to actually show data in a different manner. So like, whereas, facilities, you can use a map like this that shows the number of facilities, licensed facilities in a county in 2017. You get a lot of information here, but as Stephen was saying before, it's a coarse measure. So, when we look at things, at the address point level, here each dot represents a facility throughout the United States. And so what that allows us to do is be able to really calculate any sort of geographic measure that we want to in order to understand the availability of treatment. It's a much less coarse measure that we can use to measure things.
Do you have population denominators for the county?
Not in this, not in these maps. So we didn't adjust for the population density. These are just to demonstrate the difference between the actual number of facilities versus the address point data. But yes, I think population adjustments are necessary if you ever want to actually do any sort of analyses, regression analyses, or even just any descriptive ones as well. It's something that's not often done in the literature, sadly, as well. I think a lot of folks struggle with what the correct denominator is. Is it those that have a substance use disorder? Because then you'd have to use something like the NSDA, where it's really difficult to get access to sub-state estimates of the NSDA.
So if you do something like a DID, you just could do it with the number of facilities and assume that the population is not changing dramatically, which is kind of something that people get away with.
I think that people do try to control for population. I think it's less common to see folks do that, but they should, given the fact that you can see here that like the concentration in like treatment facilities is really located in cities and in the Northeast. And so like, I think population controls are always necessary or should be used.
Right, we're struggling with that a bit ourselves right now.
It's definitely difficult because the denominator is always the thing that folks are most interested in, of which one to use. And so this is just.
Have you made an attempt to use the NISDO estimates of people with OUD as denominators?
We've linked up the county level NISDA to the treatment facility data. We're in the process of writing that up, but we're not focused on using it as a denominator. We've been mostly just focused on trying to see the availability of treatment and how it matches up between the two.
And they let you export those county level counts back out of NISDO?
So we did regression adjusted ones. So we didn't do particular counties because that's not allowed.
Right.
So yeah,
Okay.
because we can't identify individual counties. I think you'd have to roll it up to the state to make like a heat map of some sort. But even then, you're missing a lot of the variation that you're discussing, that you're interested in. Here's another map, also similar in nature, in the sense that, again, showing at the county level the number of facilities that are in a county that offer any form of MOUD. Again, darker shading is more. But then, when you look at the actual maps with the address point data, it's similar, but, like, again, there's a lot of variation, even more variation that you can exploit. I think the last one I'll show is the fact that, it's very sparse, the number of counties with a facility that uses all forms of MOUD. There's wide swaths of the country that just simply don't have a provider. And so, it looks really barren at the county level and even worse at the address point level. Like there are just large proportions of the country that lack a provider. So here's what we did in a recent paper in drug and alcohol dependence. We actually calculated the difference in the share of individuals who actually have access to a treatment facility within a drive time of their census tract in comparison to those without a count. So for those individuals without a facility in their county. So the way you can interpret this is the bar all the way to the left is basically the share of individuals with a facility within a 50-minute drive time when they lack a treatment facility in their county. So about 76.6% of individuals without a treatment facility in their county can at least reach one within a 50-minute drive time, 50-mile distance. And that's about 31.8% for those looking for a facility with all forms of MOUD. So essentially, what this is telling us is that counties, even if you don't have a facility in a county, you still have access in some degree. And so we should really be moving away from using county as a measure for determining geographic availability of treatment.
This is telling you that people are using facilities in other counties that happen to be closer?
That are within some sort of drive time. It could be closer, it might not be closer. There's just there's no facility in that county, so you're just driving to one that's probably in an outer county.
Right.
Yeah. And even like when you're dealing with 10 miles, it's about 13.5% for any facility. So I mean, we're talking about 2.2 million people don't have a treatment facility in their county, but could access a facility outside of their county within 10 miles. So like, this is just basically saying that, county is a measure, but we should probably move away from it if possible. So we linked the data across years. The way that we did that is that we used their address and then a probabilistic matching algorithm to identify matches. How does that actually look though? So here again, I'm focusing on California. And if we take a look at whether or not Good Samaritan Shelter exists in year 2017 on the left compared to year 2016, we can see the two match up with the yellow boxes around them. Then for Mental Health Systems, Inc., we see matches across both years in purple. Santa Maria Valley Youth and Family Treatment Center is in blue. And so what this is saying to us at least is that, these are facilities, these are the same locations and same facilities. So we're able to track them over time and see if their services change over time as well. So this is kind of the identifier I was discussing before, and the fact that we're looking at panel as opposed to cross-sectional.
And you have some issues, I guess, with facility mergers, changes in name and so forth?
Sometimes, I mean, yeah, so we found that phone number is not a good use.
Right,
Name is not a good use.
right,
Address is probably the best. If so we've really focused on treatment facilities as a whole, as a location, as opposed to we're less concerned about whether or not it's like going from facility A to facility B and changing of name.
right.
Because yeah, the ownership stuff's gonna be difficult to track.
Although it might have been bought up by private equity and become quite a different type of
Provider, yeah.
facility.
Exactly. Yeah, but we would be able to track that based off of, we know what type of ownership they at least report
Right.
in the survey, but I completely agree with you. The bigger problem, I think, is this. So in 2015, you might have this Twin Palms Recovery Center captured in red. This is the listing for 2015. Now, if we look again, La Puente, you want to remember the name Twin Palms Recovery Center. If we look in 2016 and we look under La Puente, there's no Twin Palms Recovery Center listed at all. And so that might think, you know, the existing literature would be like, okay, that facility's closed. It's out. We don't have to worry about it anymore. Now, if you look in 2017, though, suddenly it pops back in the bottom left corner in the red. Same location, same name, just didn't appear in 2016. This is getting at really the cross-sectional concerns that we have here in a given year. Like a facility could just be like, I am not responding and I don't want to be listed, or I don't want to be listed, either one of those. So it's a whole different type of measurement problem. And presumably, you know, in like 2016, you could check Facebook and you can see that this particular facility was open because someone checked in for a DUI class during 2016. So this is the bigger problem, I think, in the sense that a lot of folks are using individual 1 year of these data or not adjusting for the fact that facilities simply do not respond in every year consistently. So basically, that's the discussion of how we got to the data. The way that we've done this is that we've linked the facilities together and then tried to identify what we call as a gap year and then fill those in with relevant information. Now I'm going to shift to the application portion if folks don't have any questions about how we create the data first.
Jonathan, I had a couple of questions.
Sure.
First off, so I've tried to use these data too, for creating like a variable for treatment access in New Jersey.
Yep.
And it was pretty complicated, as you know, to scrape those files. Unfortunately, we only had to do it for one state. So it's great to know that there's potentially a database out there that has all of the states. So I was wondering, is that database going to be public? And then I was also wondering what software it was that you showed to extract the information from the PDFs. And then finally, what percentage of facilities within a year agree to share that information in the directory?
So, okay, on the first one, right now, we're still trying to curate the data and to make it into like a usable format for everybody publicly. But if you have specific research questions and want to collaborate, feel free to email us. We have a system now internally that we can cut data files out. We try to be involved as best as possible, just so we make sure the data are used correctly. But it's totally usable. If you just email me after today, I'm happy to get that process started. We used Abby Viewfinder, I think, something like that, for the OCRing piece. And then for the rates, I'm hesitant to say anything as of yet. We're having a statistician really work on this and try to crunch the numbers to identify, you know, and compare rates in the NSATs to what's in the directory data. There are a lot of numbers that are floating out there that I don't know if I would report the same way. So it's not easy for us to come up with a be all and end all for a particular number for saying this is the rate. Because in every single year, it's going to depend also. So I don't have a particular number as of yet.
Okay. All right. Thank you.
Of course. Yeah. Okay. And feel free to jump in with other questions as well. I'm happy to answer them, you know, on everything really related to this. So what we did was we calculated the proportion of SUD treatment facilities that accept Medicare, Medicaid, private insurance, or cash as a form of payment. Cash we were focused really on for individuals that are uninsured. Then we calculated the proportion of counties with this SUD treatment facility accepting each form of payment. And then we calculate drive times from the centroid of each census block. And, we're trying to calculate the share of the population that has a facility within 15, 30, or 60 minutes. So it would be the share of Medicare beneficiaries, according to ACS, that have a facility within 15, 30, or 60 minutes. The share of Medicaid beneficiaries within 15, 30, or 60 minutes. And then we calculated, these were unadjusted, like we did some regressions, very slight regressions to look at the, with 95% confidence intervals, to look at, changes over time. But, I think as discussed before, it's probably a good idea in the future to do things at the while controlling for population or doing like per capita measures. This was just to try to give a general sense of trends. So here we found that Medicare was a drastic lagger compared to everybody else. In 2010, for example, only about 32% of treatment facilities accepted as a form of payment compared to cash, where like 90% did. And then around 63% for private insurance. And for Medicaid, we found about 54%. By 2021, we found that cash was accepted by 92%. And that, Medicare was only getting to about 42% of facilities. So, I mean, they're really lagging behind. All of everything but cash increased over time between 2010 and 2021. All those increases were statistically significant. So the only one that wasn't was cash. It was just basically staying the same. So we did see increases in the share of facilities accepting each of these forms of payment.
Are you expecting that Medicare number to go up?
Oh, it already has. We've started doing some preliminary work,
2022?
and it's been going up drastically. There are new rules in terms of reimbursement, especially regarding OTPs, so it has been going up.
Right.
And this is the share of counties. We found that in 2010, approximately 60.9% of counties had treatment facility that accepted cash. 50% had one that accepted either Medicaid or private insurance, and only about 41% for Medicare. By 2021, 65% had a facility that accepted Medicaid, and about 54% had one that accepted Medicare. So we're doing better, but not good enough still. And I'd like to see those numbers checked again after these recent changes in policy. Here are the drive times. We found that about 57% of Medicare beneficiaries live within a 15-minute drive time of a facility. That number is about 73% for Medicaid. And then 69.8% for private insurance. And then cash, it was also, again, still higher. The bar charts here are for 15 minutes to the left, 30 minutes in the middle, and 60 minutes to the right. So Medicare, at least within the 15-minute drive, is lagging behind, but it's relatively closer when you get to 60 minutes. So I think it's around 88% of 88% of Medicare beneficiaries have a facility that accepts Medicare within a 60-minute drive time. All to say about, like, if you have an hour, you're probably going to be able to find a provider that accepts your form of insurance, but it's probably better if we increase the number of facilities within the 15-minute drive time or the 30-minute drive time as well. And again, this is kind of showing the contrast between what we find in a county level data set versus what we find in drive time or address point data set. The fact that you can find a provider within a 60-minute drive time is a striking contrast to the county level measures. Here's a graph at the census tract level that basically just shows you where in the country, areas of the country, individuals can find a treatment facility with a 15-minute drive time. So those are areas in green. So Medicare beneficiaries within 15 minutes can get to a facility that accepts their form of insurance. Now, it's basically concentrated in the Northeast, right? Areas in yellow are those where you have to travel more than 60 minutes to reach a facility that accepts Medicare as a form of payment, if you're a Medicare beneficiary. So it's mostly in the West, Midwest. There's wide swaths of the country that are just simply lacking a provider that they can get treatment from within a 60-minute drive time. Again, this is very different than what you see with those county level maps. it seems like in the East Coast, at least Northeast, like things are very concentrated. And if we look at Medicaid too, you'll see more areas of the country are in green, which indicates, again, individuals can find a provider within 15-minute drive time. A lot less of the country is in yellow, where a facility is, more than 60 minutes away for a Medicaid beneficiary. But, this is probably a better way of us being able to target resources in terms of determining where people can access treatment, as opposed to the county. Some limitations of that study are that it's limited to licensed substance use disorder treatment facilities. We don't have data on buprenorphine waivered physicians, for example. We don't have measures of the number of beds or patients served at the facility. We don't really examine barriers to access. What are possible barriers of access? It could be that practitioners don't actually work in the individual's provider network, or that they don't accept their form of insurance. So there are a lot of limitations here. I think we're not fully measuring the availability of treatment, given that we're focused on licensed SUD treatment facilities. If we had included unlicensed facilities or BUP waivered physicians, the results could be different. But, I think this is a good indication of what the licensed treatment facility locations look like. So again, just the contrast between the two data sets of the fact that, we have the street address as opposed to the state. We have this common identifier as opposed to the NSATs. We can adjust the self-selection response bias. We're always thinking of new ways to do that based off of those gap years. And we think we can link to claims data as well using some of the information that's in the matter data. We've been working on those measures pretty feverishly to try and get a better understanding of like what's going on at these clinics. Just to give you a sense of like some possible extensions that we've been working on, we've been trying to incorporate the NSATs into our data set. We've also been working on trying to incorporate behavioral health locator data, as well as information about mental health facilities and BUP waivered physicians. So the NSATs, you can't identify a facility in a de-identified survey, right? You can't de-identify a survey respondent in an anonymous survey. It's illegal, just don't do it. But there are measures of trying to figure out like, this is probably what we think like the capacity of this facility is based off of their characteristics. So we use something called a data fusion method, where again, we're not identifying individual facilities in the NSATs. And based off of information that's both in the NSATs and the matter data, we're able to assign variables. And so like, what do we even want from the NSATs? You might be asking yourself. Well, we could get number of outpatient clients on a given day, number of residential beds, and the number of inpatient beds. So we've accumulated a series of crosswalks between the directory data or what's in the matter data and what's in the NSATs to identify how things align. And then based off of those information, we're able to probabilistically say, we think our best guess is that a particular facility has X number of beds. And so the best research on this, I think previously was at the state level. This is an AJPH paper that basically calculated total capacity for OUD treatment at the state level. And they have this really nice chart that basically goes through it, each individual state, and identifies the total capacity for treatment for a state. And that's a really nice measure to be able to do so. And they use the NSATs to some degree, as well as other data sets as well. But we think that we can supplement that information at a lower geography and calculate something like this. This is historical estimates that we've created, but it's an indicator of the number of hospital inpatient beds for particular facilities throughout the United States. These are dated metrics, but that we're in the process of updating, but you can really see the difference, at least in terms of understanding the capacity of treatment based off something like this, where you can see at the address point level or even some other geography, what we think is the capacity for treatment. This is what it looks like for residential beds, for example, as well. So this is one of the things that we've been working on. If we can't get, the claims data to work as much, this is one of our focuses as well, to try and understand like what the capacity is. So I don't know if folks are familiar with the behavioral health locator. If not, it's basically replacing those big paper directories. So it's this website where you can enter in your information and then identify a source of treatment. So you might put in that you're from La Puente in California, and then you get a listing with a bunch of a map with a bunch of facilities. Now, all the information in here is very similar to what is in the data I was showing you earlier, those big PDFs. But these data are updated on a more regular basis. So presumably facilities call in or get their information updated in this database. So we at RAND have been collecting these data, not daily, but I'd probably say like about weekly, scraping it and been incorporating it into our data system since 2019, I think April 2019 onward. So we're able to actually see within a year now changes in the availability of treatment. We've looked at things like telehealth in response to the COVID-19 pandemic, where you're able to see like, how often facilities actually update their information in the behavioral health data. So yeah, we try to do this in a more rapid and dynamic way. So yeah, you might click on this individual facility and get all of their information similar to how we would before. So similarly, the behavioral health locator data includes data on mental health treatment facilities and buprenorphine waivered physicians. And so we've already basically incorporated these data into a separate data system, one for mental health facilities and one for buprenorphine waivered doctors as well. So we have like 3 different data sets. We also prefer to keep the paper directories separate from these behavioral locator data, just because of the fact that they're not collected in the same exact way. They're not reported in the same way. It doesn't seem like the two would really interact with each other correctly. We do also expect that there's going to be some overlap between the SUD treatment facilities, the mental health treatment facilities, and the waivered physicians. That's some additional work that we've been trying to do as well, is to try and unpack these things. In terms of our next steps, we're going to link the current data with additional sources, depends on funding mostly, versus the NPI, as Stephen had suggested, using Medicare claims data, and then to Medicare claims data. Then we've also explored other claims data, hopefully Medicaid, veterans, TRICARE, et cetera. Natality files, DEA waivered physician list data, student outcomes, the TEDS and the NSDA, county block grant funding, employment labor outcomes, and then overdose rates and mortality. So there's a lot of data sets that we can link to because in general, there's been a lot of research looking at specialty substance use disorder treatment facilities and their relationship to other local measures. And so we think we can really look at all of these different research questions. We think they're all relevant and that we're capturing something different than what's captured in the NSATs. Things we're considering: what are the most important research questions to prioritize? How to engage with external partners? We have a way of doing that now. I think that's relatively easy. There's not a lot of paperwork. There's just a DUA and getting to write the research papers. And then what additional data sources and pieces of information can we incorporate? I think claims data is the #1 priority, by getting the MPIs, but we've been working on other pieces as well. I'd like to thank my co-authors on the paper. And then if you have questions or suggestions, feel free to email me. The necessary disclaimer is here that the presentation was from work supported by an NIA grant, and that the content is solely the responsibility of the authors and does not necessarily represent the views of the NIH. Thank you.
Thank you so much, Jonathan. We have just a few more minutes. If anyone does have any questions, please feel free to unmute and ask.
Well, this is fantastic work. Like a lot of wonderful work that I see, I say, well, it's great that the scholar is doing this work. Why the hell is Samson not done it in the first place?
Yeah.
But it's difficult work, and it's good to see that NIA is supporting this kind of work even at the R21 level.
Mm-hmm.
How do you mentioned earlier trying to start trying to dig into what is actually happening at these centers. Now, at one level, theoretically, they list all the different services they provide. Do they provide the volumes of the different services that they provide?
No, so they don't in the directories. We've been trying to get the claims data incorporated so that we'd be able to actually come up with ways of identifying client volumes and then to get a more comprehensive, holistic measure of what these facilities are actually doing.
So that brings you to the challenge of, for example, taking Medicare data and saying,
Yeah.
we think that this service was provided at facility X.
Yeah.
When it, you may understand better than we understand whether you're going to see the facility's NPI number, the individual clinician's NPI number, all of those kinds of issues, but that's part of your agenda?
Yep, that's it. So I recently got funded by a separate NIA grant to do something similar related to that. We've just started going through the DUA, complete the DUA processes. So now we're trying to come up with the best way to do exactly that, to identify providers, but then also, there's two sets of NPIs, right? There's the NPI 1, the NPI 2. So there's the facility organization 1 versus the provider 1. We're going to try and incorporate whatever we can and try to come up with ways to validate as best we can. We have a couple of smart computer scientists who were working on this, who came up with different options. I think in general, the best way of doing this is using the location. I think anything else is going to get you further away from what you're looking for. Name is just really a mess. And then phone number is problematic because a single location could have like 10 different locations can have the same phone number. So I think address is the best bet, and then just going from there and trying to validate.
I should certainly know this question, but CMS will not give you will CMS give provider addresses in a Medicare claim?
No, but the NPI, you would be able to get it, right? So if you get
able to get it, you get an NPI. If the NPI is a clinician, the clinician might be working in more than one site. You have all those issues.
Yep.
Peter's thought about this quite a bit. So as you get into it, because we're going to have to be dealing with these kinds of issues too, more broadly than just than just the licensed programs or the drug treatment programs. So, we have the problem of figuring out prescribers, regardless of whether they're a licensed program, for example, an FQHC, which is a whole other complexity, CCBHC, private office, hospital-based, and trying to align the institutional clinician relationship between all of those, something that the federal agency should have been thinking about long ago.
Yeah, I feel like that there's ways of doing this. I feel like there's certain data sets that would be better attributed to doing this as well. We've been just getting funded to do a lot of this stuff. We've tried several years of proposing to just like improve upon the SAMHSA directory data. And so, we're hoping to be able to make a contribution and help out the research community.
Awesome. Stay in touch. I have to run. I have to hop to 1 o'clock myself, and we should let you go.
Yeah, we are at the end of our time, but thank you all so much for joining today. And of course, Dr. Cantor, thank you for sharing this important research and your expertise with the NJX community. A really wonderful talk, and we're very grateful for it. So thank you so much.
Thank you.